Hello everyone, now let us discuss about drugs for bronchial asthma part 2. Now first let us discuss the drug classifications. The drugs for bronchial asthma are categorized into bronchodilators, leukotriene antagonists, mast cell stabilizers, corticosteroids, anti-IgE antibody. In the previous session we have discussed about bronchodilators, and in the current session we will be focusing on leukotriene antagonist, which are nothing but montelukast and zefrilukast, mast cell stabilizers, that is sodium chromoglycate and ketotifen, and corticosteroids, which are systemic and inhalational. Systemic corticosteroids are hydrocortisone, prednisolone and other glucocorticoids. Inhalational are beclomethasone, dipropionate, budesonide, fluticasone, propionate, flunitrazide and sliclizumab. Coming to anti-IgE antibody, that is Omalizumab. Apart from bronchodilators, we will discuss all the other classes. As we have discussed earlier, in the current session we will be focusing on neutralization of IgE, that is nothing but Omalizumab, suppression of inflammation and bronchial hyperactivity by corticosteroids, prevention of release mediators by mast cell stabilizers, and antagonism of released mediators by leukotriene antagonists and antihistamine antagonists. Now coming to cystine leukotrienes, they are produced by macrophages, eosinophils and other inflammatory cells in the lungs and are important mediators of bronchial asthma. And inhibition of these leukotrienes, it leads to bronchodilation. For that reason, we employ the leukotriene antagonists. Now coming to drugs, montelukast, zefrilukast. They competitively antagonize cystinyl leukotriene receptor mediator bronchoconstriction, airway mucus secretion, increased vascular permeability and eosinophil recruitment. They are indicated for prophylactic therapy of mild to moderate asthma as alternatives to inhaled glucocorticoids, aspirin-induced asthma, exercise-induced asthma and perineal allergic rhinitis. Coming to side effects, they cause abdominal pain, headache and rashes. Churg-Strauss syndrome is seen in few cases. Coming to metabolism, they are well absorbed orally and have high plasma protein bound. They are highly plasma protein bound and metabolized by CYP2C9. Coming to half-life, montelukast half-life or T-half is 3 to 6 hours, whereas zefrilukast T-half is 8 to 12 hours. Coming to dosage, the montelukast is available in the dose of 10 mg once daily, and for children 2 to 5 years of age, it is given as 4 mg and once daily, and for children 6 to 14 years of age, it is given as 5 mg once daily in the evening. Next, coming to dosage of zefrilukast, it is given 20 mg twice daily, and for children 5 to 11 years of age, it is given as 10 mg. Coming to the dosage forms or market preparations of montelukast are emlukast, Monte, Ventair, which are available as 4, 5 and 10 mg tablets. ODS of montelukast, which is available in 4 mg, 5 mg and 10 mg tablets. And preparations of zefrilukast are Zuvair, which is available in 10 mg and 20 mg tablets. The next drug is Xeluton. It is a 5-LOX inhibitor, which is nothing but lipooxygenase inhibitor. It blocks leukotriene C4 and D4 as well as leukotriene B4 synthesis. Coming to the clinical efficacy, it is similar to montelukast and it is short acting and has hepatotoxic potential. And the next class of drugs, they are mast cell stabilizers. The drug is sodium chromate. It inhibits the degranulation of mast cell by trigger stimuli by blocking calcium channels. And long-term treatment decreases the cellular inflammatory response and bronchial hyperactivity is reduced. Coming to pharmacokinetics, it is not absorbed orally and it is administered as aerosol through metered dose inhaler. Only action inhaled is absorbed systemically and it rapidly excreted. It is rapidly excreted unchanged in urine and bile. Coming to the indications, sodium chloride is indicated for bronchial asthma, allergic rhinitis and allergic conjunctivitis. The dosage forms or marketed preparations are pental inhaler 1 mg and cromal, which is available as 5 mg puff metered dose, 2 puffs 4 times daily. Fintal nasal spray 2% and cromal aqua AQ 2.8 mg per dose. 2 squeezes in each nostril 4 times. And Fintal eye drops, they contain Fintal eye drops 2%, Cromal 2% and 4% eye drops. 1 drop in each eye 4 times a day. Coming to adverse effects, absorption is negligible, bronchospasm and throat irritation are seen. Coming to next drug, it is ketotifen. It is an antihistaminic with chromoglycate-like action. It is indicated for multiple allergic disorders and the side effects of sedation and dry mouth are common. It is generally well tolerated. Coming to the dose, it is available in 1 to 2 mg twice daily and for children it is available in 0.5 mg twice daily. The dosage forms or marketed preparations are Astafen, which is available in 1 mg tablet and 1 mg per 5 ml syrup, Ketovent, which is available as 1 mg tablet, and Ketorib, which is available as 0.25% eye drops. The next class of drugs are corticosteroids. They act by inhibiting inflammatory cytokine production and eosinophilic and lymphocytic infiltration of lungs. These drugs afford more and complete sustained symptomatic relief than bronchodilators or other drugs. And they improve the airflow, reduce asthma exacerbations and may influence airway remodeling, retarding the disease progression. But long-term systemic steroid therapy may have adverse effects. Coming to systemic corticosteroid therapy. The systemic corticosteroid therapy is restored in asthma under 2 conditions. For severe chronic asthma, whenever it is not controlled by bronchodilators or inhalational corticosteroids, or when there is frequent reoccurrences. In this case, the treatment starts with prednisolone 20 to 60 mg daily and attempt dose reduction after 1 to 2 weeks of good control. And finally, try shifting the patient once onto inhalational corticosteroids. The second case is status asthmaticus or acute asthma exacerbation. Whenever the asthma attack does not respond to intensive bronchodilator therapy. In that case, start the treatment with high dose of rapidly acting IV glucocorticoid, which generally acts in 6 to 24 hours, and shift to oral therapy for 5 to 7 days and then discontinue. And next is COPD. A short course of oral glucocorticoid may benefit few patients. Now coming to inhaled corticosteroids. These glucocorticoids have high topical and low systemic activity due to poor absorption. Dexamethasone, dipropionate, budesonide, fluticasone and ciclisonide are commonly used inhalational corticosteroids. They are not considered in patients with mild and episodic asthma. They are indicated for persistent asthma and acute asthmatic attacks. The dose is generally 100 to 200 mg twice daily. Titrate the dose upwards every 3 to 5 days for long-term treatment and a maximum of 400 mg 4 times a day. Next, inhalational corticosteroids, they suppress bronchial inflammation, increase the peak expiratory flow rate and prevent acute asthma episodes. Certain withdrawal symptoms or effects are seen, such as precipitation of asthma, muscular pain, depression, hypotension, and tiredness. Inhalational corticosteroids in COPD is not very responsive. The adverse effects of inhalational corticosteroids are hoarseness of voice, dysphonia, sore throat, asymptomatic or symptomatic oropharyngeal candidiasis are most common adverse effects. Now let us discuss some of the drugs. The first one is beclomethasone propionate. It is an intranasal spray. It is indicated for perineal rhinitis. The dose is 200 to 400 μg. Dosage forms or marketed preparations are Becorite puff inhaler and Aerocort inhaler, meter dose inhaler with salbutamol. Next is Econase nasal spray. Next drug is budesonide. It is a non-halogenated glucocorticoid with high topical systemic activity ratio. It is indicated for perineal rhinitis and nasal polyposis. Dose is 200 to 400 μg per meter dose inhaler. The marketed products are Pulmicort meter dose inhaler respules and Foracort, which contains formoterol plus budesonide rotacaps. Next is Rhinocort meter dose nasal spray and Budinase meter dose aqueous nasal spray. The next drug is fluticasone propionate. It has high potency and long duration of action, and it is indicated for asthma. The dose is 100 to 250 μg per meter dose inhaler and 200 to 400 μg per dry powder inhaler. The marketed products are Flohal inhaler and Rotacaps, Flomist nasal spray. The next drug is flunisolide. It is a topical steroid, seasonal and perennial rhinitis. It is indicated for seasonal and perennial rhinitis. The dose is 25 μg per nasal spray. The marketed preparations are Cintaris, which is available as nasal spray. The next drug is Cislisonide. It is a prodrug that is cleaved by esterases. It is indicated for asthma and the dose is 80 to 160 μg per meter dose inhaler. The products are Cislis meter dose inhaler. Coming to next class, anti-IgE antibody, which is Omalizumab, the drug. It is a humanized monoclonal antibody against IgE which neutralizes free IgE in circulation without activating mast cells. So IgE levels are reduced. This leads to inflammatory mediator release inhibition, and then bronchoconstriction is inhibited. It is administered subcutaneously. It is indicated mostly for extensive asthma. It is very expensive and is used in cases such as resistant asthma patient, patients with positive skin test, and patients with raised IgE levels who require frequent hospitalizations. Coming to the choice of treatment, for mild episodic asthma, in which case symptoms are less than once daily, inhaled short-acting beta-2 agonist at onset of each episode can be given, and they does not require a continuous therapy. And for seasonal asthma, low doses of inhalational corticosteroids 3 to 4 weeks before the anticipated seasonal attacks and continue till the season ends. In some cases, inhaled short-acting beta-2 agonist also work. And for mild chronic asthma with occasional exacerbation, symptoms occur once daily. In such case, regular low dose of ICS, which is nothing but inhalational corticosteroid and leukotriene antagonists, can be given. Episode treatment with inhaled short-acting beta-2 agonist is advised. And for moderate asthma with frequent exacerbation, where the asthma attacks are more than once per day, inhalational corticosteroid plus inhaled long-acting beta-2 agonist. In some cases, for nocturnal asthma, sustained release theophylline plus inhaled long-acting beta-2 agonists are also used. And for severe asthma, there will be continuous symptoms and frequent exacerbations. They require regular high dose of ICH plus inhaled long-acting beta-2 agonist twice daily. Additional treatment with leukotriene antagonist and sustained release oral theophylline and sustained release oral beta 2 agonists. For the treatment of status asthmaticus or refractory asthma, hydrocortisone hemisuccinate or any equivalent dose of glucocorticoid 100 mg IV followed by 100 to 200 mg 4 to 6 hourly infusion should be given. Additionally, nebulized salbutamol, which is given in 2.5 mg to 5 mg plus ipratropium bromide 0.5 mg intermittent inhalation driven by O2. High flow humidified oxygen should be given to treat the upper respiratory tract infection. Whenever upper respiratory tract infection occurs with status asthmaticus, or to generally treat the status asthmaticus also, high flow humidified oxygen should be given. Salbutamol, terbutaline, 0.4 mg IM or subcutaneous may be added since inhaled drug may not reach the small bronchi due to severe narrowing or plugging with secretions. Intubation and mechanical ventilation, if needed, should be provided. Treat chest infection with intensive antibiotic therapy and correct dehydration and acidosis with saline plus sodium bicarbonate and lactate infusion. Thank you for watching. Please subscribe for further videos on pharmacology and other related pharmaceutical sciences.